for inviting me. It's my pleasure to be with you. نسأل الله عز وجل في هذا اليوم الكريم أن يرحم بالعباد والبلاد من هذا الوباء وهذه الجائحة إن شاء الله, ونرجع نشوف بعضنا بعض إن شاء الله الكريم. So I was asked by my colleague from Lilly to speak about the current systemic treatment option for metastatic gastric cancers. So we know gastric cancer is a very aggressive and very devastating. And as you can see, there is 22% only survival compared, for example, for the prostate and metastatic and breast cancer. As you can see, the prostate 77, 63, but unfortunately in gastric cancer, it's only 22. We know clearly in the gastric cancer, it is not one disease. We considered gastric before as one entity, now it's not anymore. This is actually well known and was published in the Natures, where they divided the gastric cancer to 4 important types based on the mutation and chromosomal abnormality. Although this was published in 2014, almost 6 years from now, and unfortunately, we are not using it as a medical oncologist. So it is there, and we know it's clearly, and we know the implication on the treatment, but unfortunately, it is not has any clinical validations in our practice. And we know clearly there is a 4 active chemotherapy agent in metastatic gastric cancer, the common 5-FU, taxane, platinum, and other irinotecan. And all of this is a very important fundamental therapy in patients with metastatic gastric cancers. We know initially that from this very important meta-analysis, the chemotherapy versus best supportive care carrying an overall survival therapy. Because if you go back in 90 and before 90, actually there was no hope for gastric cancer patients. And the big question, is there any benefit from adding chemotherapy to those category of patients? And there was some controversy regarding the benefit of chemotherapy. Subsequently, we have this meta-analysis which showed that chemotherapy actually it's carry important survival benefits compared to the best supportive care. However, if you look to the response rate for the various therapy that we use at that time, it was only approaching less than 20 to 25%. This is the response rate, and there was no overall survival. This is lead to another theory, monotherapy versus combination chemotherapy. And actually, based on that, again, the meta-analysis showed that the chemotherapy was superior, combination chemotherapy superior to the monotherapy. And from there, the standard of care actually for combination or doublet therapy rather than monotherapy. And subsequently, we have a cascade of clinical trials which show there is a benefit clearly from 2 medications. And the big question is 2 medications better than 3 medications, or 3 medications better than 2 medications? And we know clearly that 3 medications carry more or superior overall survival benefits. However, in other side of the equation, it's carry more of side effects. So this is lead actually to most of us actually adapt to have a combination therapy with 2 regimen rather than triplet therapy. The big question actually became as what's important of, we know the 5-FU is a fundamental medications. What about the substitution of 5-FU with capecitabine in the oral form? And what about the substitution of cisplatin to oxaliplatin therapy? And based on a very famous published in New England Journal of Medicine in 2008, REAL 2 trial, which showed the 5-FU is equal to capecitabine, cisplatin to oxaliplatin. And this trial actually changed most of our practice now to keep the patient on FOLFOX chemotherapy or Zelox chemotherapy in a first-line setting. And as you can see in the best supportive care at that time, 3-month improvement in survival. And with the use of the regimen now, we are reaching to almost 10 month overall survival in the first line setting, which is actually some improvement from no therapy to almost 10 months with doublet or triplet therapy. This is in the first line setting, and subsequently, there was a small number of patients at that time. They are able to go to the second line therapy, and subsequently, we have three important phase 3 trial. The first trial, what about docetaxel versus supportive care and post 5U or platinum-based therapy. And as you can see, there was some improvement of 2 months with adding docetaxel chemotherapy. Then another important trial with 202 patients, again, to use docetaxel or irinotecan, and again, versus supportive care, give us almost 2 months. And when they compare irinotecan plus versus supportive care for 40 patients, actually, there was again 2 months. So the chemotherapy adding only 2 month benefit in second line therapy, and the best, as you can see, 4 to 5 months in second line therapy. So third line chemotherapy, we know that patients who progress into line of therapy, which is actually quite small number of patients, they were in a very important clinical trial randomized to TAS 102, some sort of 5U capecitabine therapy, to placebo, and in matter of fact, in third line, it showed clearly there is an overall survival with a very significant hazard ratio of 69 and p-value of 0.003, with adding almost 2 months in third line setting. So we know clearly that gastric cancer, it's very rich with a lot of mutation and targeted that can work nicely with it. So the first, targeted was HER2 in gastric cancer, and it is almost 15%. And there was 5 randomized phase 3 clinical trial. Toga, Logic, Jacob was the first line, and Caspi and Titan was in the second line therapy. And as you can see, the only positive trial was actually trastuzumab, which adding survival benefit when they compare it with 5U cisplatin versus 5U cisplatin trastuzumab in patient with HER2 positive, and for the first time adding another 2 months. So we reached to 13 months in those category of patients. And when they did exploratory analysis for those who has a FISH positive or immunohistochemistry of 2, they, for the first time, we reached in the first line setting 16 months in favor of anti-HER2 only in this category of patients. However, this is only the percentage of HER2 was only 15%, and this is the only clinical trial for HER2 in the first and second line therapy showed survival benefit. And now this is a become standard of care. Any patient with metastatic gastric cancer, we send for HER2 testing. So as you can see, for those category of immunohistochemistry of 2 and FISH positive, we reach for the first time to 16 months compared to the 3 months with the best supportive care. What about the anti-EGFR, cetuximab, blinatumab, and nituzumab? All the 3 important known anti-EGFR was tested in 3 important clinical trials, and unfortunately it was negative and there was no benefits. Now, when we look for the antigenesis in gastric cancer, as everybody knows, it's a very important form of formation of the tumor by actually stimulation of the angiogenesis and migrations of the tumor, and later on to promotions of cancer cells. And bevacizumab was tested in the first line setting, and unfortunately, as you can see, the 2 curve was identical, and it was completely negative in the first line metastatic gastric cancer in phase 3 clinical trial and considered as negative. And again, another important fast endothelial growth factor, ramucirumab, when it was examined, was cisplatin capecitabine versus the placebo, plus cisplatin capecitabine in the first line setting. Actually, it showed there was no overall survival benefit. So, in the antivascular endothelial growth factor, in the first line, it has no rule. However, in the second line, this is actually changed with a very important phase 2 clinical trial, phase 3. The first one actually with a combination chemotherapy plus targeted therapy, which is ramucirumab plus paclitaxel chemotherapy, or paclitaxel plus placebo. The primary endpoint was an overall survival. And ramucirumab was tested against placebo in second line as a monotherapy, and they were looking for overall survival. Now, if you look for the combination therapy versus paclitaxel active chemotherapy, you can see for the first time we reached to 9.6 months. This is in second line therapy with improvement of 2 months and a very significant p-value. And again, when they look for the ramucirumab as a monotherapy, it's actually extending significantly the overall survival by additional of 2 months. Remember, this is again was tested alone in the regard trials. Now, another important target is a MET. Actually, MET is a very important. We know the hypoxia and
الصوت ما هو واضح.
ايوه دكتور عبد الله وقف التصوير.
Yes, maybe he just have lose his connection, but inshallah he'll be in a while.
الصورة رجعت بس ما في صوت.
We can't hear you, Dr. Abdullah. Could you unmute for your mic, please? Could you connect to your audio, please?
دكتور عبد الله سامعنا؟
Yes, yes. Now it's clear. Do you hear me now?
ايوه الحين احسن. تفضل.
Okay, fair enough.
ارجع السلايد اللي قبلها معلش.
Okay, sure. Okay, now this one. So we know clearly, yes, okay, thank you, Dr. Fatma. I'm sorry for this. So we know clearly the hypoxia-induced factor is a very important in metastatic gastric cancer. And in phase 2 trial, it's given very encouraging results. However, this was tested in phase 3 trial, and unfortunately, it came negative in 4 important clinical trial phase 3. Now, we know clearly that, again, the DNA damaging agent like the PARP inhibitor, it's carry a very important pathogenesis rule in patients with metastatic gastric cancer. And unfortunately, it was tested in a very important GOLD-3 phase 3 trial. And actually, there was no difference in overall survival, and the result was considered as negative. So a very important targeting the stem cells pathway. It's again a very brilliant idea and a very important mechanism in the pathogenesis of metastatic gastric cancer. And again, was tested naproxen in second-line therapy, and unfortunately, it was negative clinical trials. So the mTOR pathway, we know clearly it's very important in pathogenesis of gastric cancer, and was tested in a phase 3 trial in two important clinical trials, GRADUE-1 and RABDAC trial, and both of them actually came negative with no improvement in survival. So we know that the immunotherapy now to play a major role in gastric cancer, and definitely we know those who has a PD-L1 positive carry worse prognosis that compared to the PD-L1 negative. And we know immunotherapy was tested in the first line setting, heading with the chemotherapy compared to the chemotherapy. And unfortunately, it showed there was no improvement for all comer population, and only positive for those who has an MSI high patients. In second line immunotherapy, pembrolizumab was tested again in second line therapy after progression of cisplatin 5-FU, and they compare it to the physician discretion, which is actually only paclitaxel or irinotecan or paclitaxel chemotherapy, and the result actually came very disappointing in terms of the pembrolizumab, and it was only positive for those who have high MSI or those who have score more than 10. The only rule of immunotherapy was actually from a China trial, which is actually attraction trial, which showed those who was heavily treated with chemotherapy in first and second line therapy. Nivolumab showed an overall survival in those category of patients, and nivolumab was approved only in Asian guideline, and unfortunately not in the NCC guideline, and even not in the ESMO guideline. So the role of immunotherapy in gastric cancer is still very controversial, and it only has a good role for those who has an MSI high patients. This is the clinical trial that we were speaking about, the Keynote 62, when they compare pembrolizumab alone or pembrolizumab plus chemo or chemotherapy alone. And a matter of fact, only as you can see, the only combined positive score more than 10 is the only patient that they can benefit, and this is actually only 10 to 15 patients of our population. And a matter of fact, the highest benefit was actually for those who has an MSI, and as you know, actually 15% of the patients with metastatic gastric cancer, they carry this MSI separation of the curve, regardless of the PD-L1 status. So Keynote 62, this is actually in the second line therapy, and a matter of fact, as we spoke before, there was no overall survival benefit, and the only survival benefit was clearly with those who has MSI high populations. This is actually the NCC guideline. As you can see, the first line to medication is the preferred because of the low toxicity and very comparable overall survival with triplet therapy. And as you can see, the preferred regimen, FOLFOX or Xelox chemotherapy or 5-FU plus cisplatin therapy. And actually, they enumerate all the other options, either with doublet or triplet therapy. Now, again, I am going to concentrate on this slide. As you can see, in the first line from the best supportive care was only 3 months, and we reached with trastuzumab plus chemotherapy to almost 13-month improvement in overall survival. And in the second line, you can see the major benefit. Actually, we approach almost 10 months in second line therapy with paclitaxel and with paclitaxel chemotherapy and Cremeza. And I don't know what's happened. Yes, okay. So, okay. So you can see now this clearly the overall survival benefit. As you can see, all this therapy was almost 4 to 5 months. And for the Cremeza now we reached to 9.6 month with improvement of 2 month improvement in overall survival. So this is actually adapted in the NCC guideline and the ESMO guide. This is standard of care for any patient in second line therapy. We prefer to go with the combination therapy. However, if you don't have it, monotherapy showed again overall survival benefits. So this is a very important slide. In the last 20 years, there was almost 22 phase 3 clinical trial. Only 5 of them showed a clinical median overall survival benefit. And as you can see, only adding 1 to 2 month survival benefit. This is explaining how aggressive, how devastating disease that we are handling. So, okay. So actually, this is my sequence for the patient who has metastatic gastric cancer, non-MSI, which is actually 85% of the populations. 5-FU oxaliplatinum phase, patient progressed, second line, paclitaxel, ramucirumab. If patient progressed, we go with TAS 103, and if we have any other patient at the times, we can go with the nivolumab. Now we're adapting FLOT chemotherapy in locally advanced disease. However, we know that almost 40 to 50% of those patients have progressed. So FOLFIRI and ramucirumab shown and proven to show efficacy in the last ASCO meeting and based on phase 2 trial. It's a very encouraging, with a very encouraging result. So FOLFIRI and ramucirumab in second line therapy. If patient progress, we go with TAS 102 and then consider immunotherapy. However, for those who has high MSI, I do believe, which is almost 15% of the populations, immunotherapy, it should be the standard of care. And actually the big question, what we should go in the second and third line, shall we consider chemotherapy or chemo versus targeted therapy or chemo plus targeted therapy? Still, we don't know about in this category of patients in second and third line.
If you can wrap up, because the time is up.
Okay, so the last slide, metastatic gastric cancer is still a very aggressive disease with high mortality. In spite of the progression we have, FOLFOX or Zelox is typical first line of therapy with or without trastuzumab based on the HER2 status. Ramucirumab single or with paclitaxel is typical second line therapy. And definitely for any patient with high MSI, immunotherapy, standard of care is actually to go with immunotherapy